So when we are treating hyperkalemia, three things should be there in our mind. First is, we know that there will be disturbance to the action potential of cardiac muscles. So we have to stabilize cardiac membrane. Cardiac membrane. This should be the first priority. Then we have to try to push the excess potassium into the cells. So that is the safest place during that emergency. So redistribute. Redistribution should be the second focus. Then we should aim at removing excess potassium from body. So these three should be our goals. So we know that to stabilize cardiac membrane and to increase the threshold of action potential, we can use 10% of calcium gluconate, 10 ml, which can be given IV over 10 minutes, or the same 10 ml of calcium gluconate, 10%, 10 ml calcium gluconate should be injected in 100 ml of 5D and given over 20 to 30 minutes. This is second option. Or else we can even use calcium chloride. So about 3 to 4 ml of calcium chloride can be given over 2 to 3 minutes IV. So these are some 2-3 options. But the thing is, the mechanism is, this calcium will stabilize the membrane and it will increase the action potential threshold. Now this calcium will start its action in 1 to 3 minutes. So very rapidly it will start its action, start of action. That action is nothing but to stabilize the cardiac membrane, and this stabilization will last for 30 to 60 minutes action. Now we have stabilized the membrane and it will remain stabilized for about 30 to 60 minutes, so that it is like we have got that bonus time, so that in that time we have to focus on pushing the potassium into normal state. So for that comes the next column, that is, we have to focus on redistribution. So how to redistribute the potassium? We know that we will use dextrose plus insulin. So what we can do, just give 10 units of regular insulin bolus, with immediately followed by either 50 ml of 50% dextrose, or the common one which we get in all the setups, 100 ml of 25% dextrose. We can even choose to mix this insulin into this dextrose and we can give. This should be given over 20 to 30 minutes. And we know that it will start its action of pushing the potassium into the cells within 5 to 10 minutes. 5 to 10 minutes. And this action will last for about 4 to 6 hours. So even if there is excessive potassium, it will be into the cells for 4 to 6 hours till the action of this insulin and dextrose lasts. That is first thing. So related to this, I want to tell 3 important confusions which residents commonly face. That is, what happens if we give dextrose without giving insulin? Because some might think that even dextrose will stimulate insulin production, so no need to give insulin. So giving dextrose directly will cause increased tonicity in the blood. Increased tonicity, which will drag out water as osmotic diuretic. So along with this, there will be dragging out of potassium out of cells, again worsening hyperkalemia. This we have to remember. So it is always should be given with insulin. Second confusion will be, suppose there is a risk of hypoglycemia. For example, the individual is elder and we are thinking he might go into hypoglycemia using 10 units of insulin. So for that we can do, after this we have to give maintenance infusion of 10% dextrose, that is 10D or even 5D at 50 to 75 ml per hour. So we can utilize this dextrose rich fluid so that there will not be any hypoglycemia. This is the second confusion. Third one is, what if the individual is already a diabetic, or if the baseline sugars are only high, if it is more than 200 to 250 blood sugar levels already, that time we can give only insulin without dextrose. So this can be given if we are worried about hyperglycemia in this state. So these are the three important things when it comes to redistribution. And we know that this action will last for 4 to 6 hours. So that's why we have to evaluate for the cause of hyperkalemia in that time gap, and we have to repeat serum potassium levels to look for reversal of ECG manifestations and even lowering of hyperkalemia. If the potassium is still high, we can repeat the same process. We have to again, after 4 hours, we can again stabilize the membrane for 30 to 60 minutes, and we have to give 10 units plus dextrose again, so that the action again will last for 4 to 6 hours. This is first thing. Second one is we can utilize beta agonists, that is albuterol or salbutamol nebulization. Salbutamol neb. Here important point to remember is we have to add this respule with 4 ml of NS, and the nebulization should be given for 10 minutes. So these things we have to remember. So if we continue the nebulization for about 10 minutes, it will act properly, so that again the action will last for 4 to 6 hours to redistribute the potassium into the cells. This is about redistribution. And in causes, we listed out that majority of the times, if there is no kidney injury or if the individual is not elder, diabetic or CKD patient, most of the times it will be just because of the distribution abnormality of potassium. So if it is like that, till this stage, there will be reversal and the problem will solve at this level only. Suppose the individual is having actual hyperkalemia in the body. So what happens? The action will last for 4 to 6 hours, but after 4 to 6 hours, if we repeat the potassium levels, again it might be increased. Or by the time if we work up, we will get to know that there is some proper elevation of the potassium in the body, and it is not just because of redistribution. So that time we have to focus on removing that excess potassium from the body. So for that, what we can do, there are numerous resins and potassium binders in the market. For example, when it comes to resins, we know that there is sodium polystyrene sulfonate, that is SPS. So what it will do is it will exchange sodium with potassium in the gut. So potassium will be lost, in feces. That's how it will try to remove out the potassium from body. And there are some potassium binders, for example pytiromer. Again, it is a calcium based product which will exchange calcium and potassium, leading to potassium loss from gut. So these things will mainly focus on excretion of the potassium from gut. And we know that according to normal physiology, only about 10% of the potassium in the body will be lost through feces. So this is kind of over stimulation of the mechanism. That's why when it comes to SPS, there are reported intestinal necrosis. So we have to be careful when we are using this mechanism of excreting potassium through gut. Instead, we can consider dialysis to remove excess potassium from the body. Or if there is volume overload with hyperkalemia, commonly as we see in CKD patients, it's better to use diuretics. That will help for both, for excess volume also, and excess potassium excretion is also done with diuretics. And one more scenario which we see is hypovolemic AKI leading to hyperkalemia. So here we can't use diuretics. Here we have to use IV normal saline. So if we give this normal saline, there will be good reach of sodium at distal tubules. So when sodium reaches in good amount, it will be reabsorbed well, so that in exchange potassium is excreted. So like that, normal saline will help in case of hypovolemic AKI causing hyperkalemia. So these things we have to keep in mind. This is about third column. So to summarize which mechanisms, first we will stabilize the cardiac membrane to avoid arrhythmias using calcium gluconate, so that we can buy that extra 30 to 60 minutes to do other actions. Then we mainly focus to shift the potassium into the cells using glucose and insulin, even beta agonists like salbutamol. So this usage will give a time period of 4 to 6 hours, because their action will last for that duration. So in that time, we have to find out the cause of hyperkalemia, and if we get any cause, or if there is actual rise in the potassium levels in body, we have to next focus on removing that excess potassium from body, especially using dialysis or diuretics. There are some resins and potassium binders which will excrete through GIT, but we have to be careful when we are using those things. This is about hyperkalemia and its management. Hope you got the mechanisms also, which is very, very important. Thank you so much.